Expressed on this show do not reflect that of the staff and management of WNOV and W293CX 106.5 FM Courier Communications Milwaukee, but are the sole comments of the host and guest of this particular show.
It's like a diamond ring, it's a precious thing, and we never want to lose it. It's like a favorite song that we love to sing. Every time we hear the music, and we're in this love together. We got the kind that lasts forever. We're in this love together, and like berries on the vine, it gets sweeter all the time. It's like a rainy night and candlelight.
Good morning, everyone. This is Karen Dotson from the Medical College of Wisconsin. I'm the program director for the All of Us Research Program. And we have Dr. Kevin Izard with us today.
Good morning, people. Good morning.
My family, my what can I say? My famous, I always call you famous, my best family physician.
That's it.
How you doing this morning?
Robin to her Batman.
All right. Yeah, we're a team. We're a team. Yeah. So it's good to see you this morning. It's good to have all the listeners listening to us this morning. And we're going to have a good conversation today.
Yeah.
We're going to talk about, Dr. Izard and I, we've been looking at some reports that have come out about research and what they've been finding with some of the data from the All of Us Research Program. But then we're also going to have our special guest that's going to be talking about autism spectrum disorders. We'll be having that on the second half of the show.
Yeah, that actually looks pretty good.
Yeah. So
it's the first time we've been in the studio together for a while.
It's been a while, and I'm glad to be back.
Yeah, Karen had a respiratory thing going on. I had the flu last week.
Yeah, it's been about a month and a half or 2 months. I was on steroids and everything, but I'm making it through, so I'm not complaining.
That's right.
Yeah.
Be careful about the flu. The flu is really bad this year. You know what they try to do every year? They try to predict what's going to be the strain, because the flu changes every year. And that's the reason why you don't have permanent immunity to it. It changes. It's a little bit every year, so you get these variants that come out, and so they try to predict what's going to be the variant going around. So they look at, because the southern hemisphere has their winter when we have our summer, and vice versa. So they look at what was going around South America, Australia, New Zealand, and they figure, okay, those strains are probably going to come up here, and that's going to be the predominant strains for North America. Sometimes they do a good job. Sometimes it works. Sometimes it doesn't. Looks like this year it wasn't that great, because a lot of people we're seeing with the flu have been vaccinated even, and they're still getting it. Now, what happens though is if you do get it, it tends to be like my case was really, really mild, and so you get a milder case and less severe. But it's not too late to get the your flu vaccination.
Oh, really? We can still do it.
You can still do it.
Okay. How long can you go before the end? Well, closer to spring, they suggest.
Yeah. So you can go until it's gone. So you can probably find the flu shot until April. Still out there. And it takes probably a couple of weeks after you're vaccinated for you to develop immunity. So it's still out there. So you can still get it. Usually the signs you're going to look for is usually just a sudden onset of symptoms. So, the flu, we talk about like stomach flu. Stomach flu really is not the flu. Stomach flu is a gastrointestinal virus. So like earlier this year, we were seeing norovirus, which is a gastrointestinal virus that causes diarrhea, causes vomiting. The flu really does not, it's a respiratory infection, so it does not cause diarrhea and constipation and stuff, or diarrhea and vomiting. It feels, usually people will tell me this, the typical story is this. So someone will say, doc, I was feeling fine yesterday, and about 3 o'clock, I just felt like a truck hit me. I just felt tired and body aches. I went home and I got into bed and I slept all day, and got the next day and I was just so tired I slept all the next day. That's the flu.
Yeah, it
So
really wears you
yeah,
out.
it
And
does. You get
hits you
that.
like a bomb,
It hits,
right?
yeah, and then that's it. The suddenness is usually one of the the symptoms of it. Is that they can people can usually tell you when it was. It was 3 o'clock that I just felt like crap. So um,
Well, I'm glad you're doing better,
yeah,
doctor.
yeah. So
I'm glad
be
you're
careful
doing
out
better.
there. If
Yeah,
if you have
yeah,
those symptoms, stay home.
yeah.
Please
Because
don't
I
go to
mean,
work.
yeah, people give it to each other, and I
Yeah,
know
yeah.
it seemed like I kept having reoccurrences of different things.
Right,
But
right.
hopefully, we're doing well now. Thank
Yeah,
God for
yeah.
prednisone and
Right. Other thing you can do too is if someone in your household has the flu, you can actually, there's a medication, Tamiflu, that you can get, acetaminophen. You can get that to prevent yourself from, or to reduce your risk of getting the flu.
oh, really?
Yeah. So,
Okay.
but
Mention that
again,
again.
it's called Tamiflu.
Tamiflu.
Yeah,
Okay.
or
So you need to take it
acetaminophen.
to be
Yeah,
more
but
proactive.
you got to get it. Yeah, you got to get it like right when you come in contact with
Okay.
it. So like if someone in the household has it, and then also if you get the flu, you can get Tamiflu for yourself too. If you get the flu, you got to get it within the first, really as soon as possible, but at least the first 48 hours. The thing about it, it reduces the duration by an average of a half a day. So it's not
Oh, wow.
right. We spend
Half
the
a day you're
money
gonna
and
be
right,
sleeping anyway,
right,
right?
right.
So
So
yeah, but that's nice to know. And it's kind of interesting because I have a sister that's also a neurologist, and we were talking about some of my symptoms and
hmm
challenges, and because I have some other challenges with my immune system, she was just saying sometimes your immune system acts up a little crazy,
hmm
and it doesn't know it doesn't respond, and it overreacts, and
right,
so that's why sometimes you have to get the steroids to
right.
to
Yeah,
counteract that a little bit. Is
yeah.
that correct,
Yeah,
doctor?
and a lot of times people don't realize, but you can get, they call it the post viral syndrome. So after you have a respiratory infection, you can still make a lot of mucus and stuff afterwards. That might go on for even for a couple more weeks. So you
Mm.
might have that post nasal drip and have a cough. Even though you're feeling better. So that's a kind of a common occurrence after you had the flu. And plus, and with any viral thing, you can really still be tired, just don't have your energy level back. That's all that's normal.
Doctor, that's enough about us today. We're going to talk about some important research, right? I
Yeah.
mean, I know that people have been challenged and everything with the flu, the virus. There's been a lot of stuff going on with the respiratory systems. But, I was looking, and actually, there was a newsletter that came out through the All of Us Research Program talking about some very interesting data. That these researchers have really been doing. And the reason why I'm bringing this information to you all is that, by joining a research program makes a difference. We talk about it all the time, but joining a research program, the All of Us research program, just we really do data, and it's not a clinical trials, but there's some other things that you can do too. And there's other data systems as well.
You
But
want to tell the people the difference between being in a research study and being in all of us, how it's different, because
yeah,
they're
like
not
a
really signing
clinical
up for
trials,
yeah.
yeah. Like a clinical trials is where you actually might have some types of health related issues going on. And so there's medication that they're going to give you to see if you respond to it. And there's
hmm
some that you don't get the medication. And they take a group of people to see exactly their reaction behind that medication and that treatment to see if it's effective. And that's really trying to get that medication to the next level of being able to help people. And so, that's part of a clinical trial.
Yeah, yeah, they've already identified you as somebody that they want to do a specific study on. Maybe you have a condition, or maybe you have, because of your genetics or something, they've targeted you because you are a person of interest. With all of us, it's just taking people, or groups of people, and getting their information so that someone in the back end can go back and they can look at that
Right. So it's
information.
getting the data, putting it in a database. So
Mhm.
researchers, there's probably, I think it's over 10,000 researchers now in the researchers database. And these are individuals or researchers that have been approved by going through a process to ensure that they know how to use the data and how to make sure we keep our participants safe. And
Mhm.
they'll pull that information based on, just say, like, they might say, okay, we want an African American woman from 30 to 40 that maybe has hypertension or something like that, or diabetes. And so they'll pull from that database. And from that database, and they can also look at your electronic health records to see exactly what types of medication you were on, was it
Mhm.
effective or not. And, you know, that's really how the All of Us research program works. And so, you know, if you are interested, we can have one-on-one sessions with you by calling our phone number at 414-955-4629.
Yeah. Actually, before we get into this, when I went to that website looking at the update, there was a letter from the program director for All of Us. So All of Us is a NIH program, so National Institutes of Health. So it's a federally sponsored program, and everybody's hopefully you're well aware of all the budget cuts that are going on. And so and this was in December. This is actually before the budget cuts were in full effect. And so the NIH director, Monica Bertignoli, testified before the budget committee of the House of Representatives, and she was actually warning them that that if they make further budget cuts, that it really can affect programs like this. And one of the things that she's pointed out, she said, meanwhile, we're facing potential revisions to our plans and priorities that may affect the following activities. And the first among them was engaging communities historically underrepresented in biomedical research, including those living in rural areas. So again, my thing, if we're not at the table, we're on the menu, and things like this, I truly believe are a plus for us. We need to be in these studies. We need to make sure that we are included in these research projects, that when they make treatment plans and protocols for for different things, that that they've looked at us, because some of these things may apply to us, but some of them may not. And so as as they start cutting things in Washington, one of the first things to go are programs that are targeting diversity and equity. And so when we talk about equity, we're talking about healthcare disparities. Those things are going to be first thing on the block. So the chopping block. So make sure you tell if there's something that you feel is important. One, supported by by being a part of the project, but also let your representatives know that this is something that's important for you, because we need to make sure the funding continues for things like this.
Thank you, Dr. Izard. That
Mhm.
is so important when we start looking at some of the research. And, I was looking at some of the research that was presented, was talking about diabetes. And,
Mhm.
we've been having shows that talks about, type 2 diabetes and some of the challenges that people have with it and the medications. But one thing that was really found in this study, and it was so interesting because the study pulled from around 250,000 participants in the database. So that's quite a few.
Mhm.
And what they have discovered is that a lot of times people that are on diabetes medication, they also need to have medication for their heart and to be treated in that as well.
Mhm.
And so I thought that was really interesting that that a lot of times there needs to be other medications to help along with your diabetic
Right.
medication.
That's something that we've known for a while, that if you have diabetes, your risk of having a heart attack is the same as someone who's previously had a heart attack. So, so there's something about diabetes that increase your risk of having heart disease. Now we know diabetes affects small blood vessels, so it affects the small blood vessels in your eyes, so you're prone to to developing blindness. They call it diabetic retinopathy. It affects the small blood vessels in your kidneys, so you're prone to developing nephropathy, so kidney disease. It affects the small blood vessels in your extremities, so you're more likely to have problems with circulation issues. So that's why diabetics are more prone to having amputations. Um, and so, but it also affects the small blood vessels in your heart. And so, again, you're more prone to have heart attacks and strokes. So we've known that. And so, was another thing that's interesting, and some of the studies that came out from looking at diabetes is that they found that diabetes isn't. We always talk about type 1 and type 2 diabetes. Type 1 diabetes is people who don't make insulin. And that's what they used to call juvenile onset. Those are people that they don't make insulin. If they don't have insulin shots, they're going to die. So they don't have the option of taking pills. They have to take insulin. That's a minority of people with diabetes. Most of them have type 2 diabetes. And type 2 diabetes is when you're insulin resistant. Now, the good thing about that is that you can reduce that resistance by losing weight and lowering your carbohydrate intake. But now they're finding that there's probably like at least 8 different kinds of things that different kinds of diabetes. They're finding that and some of these subtypes are make people more prone to developing some of these problems. And this is important because when someone is newly diagnosed with diabetes, you make recommendations and you say, okay, we know your risk for heart disease goes up. You probably should be on a statin medication. And we start doing all these different things. Maybe we'll be able to figure out by looking at your, get a blood sample, look at your genotype and say, oh, okay, you have type 2B or type 2A or, whatever. And that makes you more prone to this. And we should put you on this medication versus this medication because you're more likely to develop kidney problems than heart problems. And so that's again, and
this
that's all
very significant.
It is very significant. Yeah.
I mean, I was just looking at that and I was like, we've always heard about, type 2 diabetes, but now there's like 8 subgroups. And so what group are you in? I mean,
right.
That's something that Dr. Izard, is that something now that people can talk to their doctor more about?
Well, it's still cutting edge. It's not out there yet, but I think that's the whole goal of precision medicine is that, we're trying to push to this place where, when you get your annual exam, one of those things that you get at some point is, a genetic analysis. And we're looking at certain genes and we find out, okay, if you have, this genotype, you're less likely to, respond to this blood pressure medication, or you're less likely to have, or you're more likely to have problems with statins. And so it's going to cause you muscle pain. So we probably shouldn't put you on this type of statin. So we're not there yet, but in the near future, we will be able to look at your specific genotype to make medication recommendations. So we're not, because right now it's trial and error. We give you a medication, we see how you do with it. We might go up on the dose, we might go down on the dose, we might change to something else. But it's trial and error, and we're getting to a point where it's going to be less of that and more directed. Especially with cancer stuff, that's a big one. Chemotherapy.
Yeah, because I think when we were looking at that research study, there's like over 100 different types of cancer.
Yeah.
No, it's over 100. There are currently more than 100 chemotherapies to treat cancer. I said it wrong. So we're looking at over 100 chemotherapies to treat cancer for each patient.
Right. And the thing about cancer is really simply said, it's just cells in your body that have lost control and they replicate. Okay, they keep reproducing and they move from wherever they were supposed to be to other parts of your body, and in doing so, they destroy those other parts of the body. So, for instance, if you have lung cancer, the lung cancer might go to your brain and so you get lung cells that are growing in your brain, and in doing so, it destroys your brain. So you end up dying from the other cells that cancer is destroying. So what you do with chemotherapy is that you start killing all rapidly growing cells, because again, we know these cells are reproducing, they're growing fast. So We're gonna give you medication that's gonna kill everything that's growing fast. Well, guess what? So the cells in your intestine, your gut, are rapidly growing. Okay, and that's normal. They're supposed to. But so when you give chemotherapy, guess what? You kill all the stuff, the cells in your intestines. You kill your hair cells, which are rapidly growing. So guess what? The hair falls out. So all those side effects you get from chemotherapy are because it's not directed. It's killing everything. And so it's trying to kill the target, but there's collateral damage. And that's so as we start targeting these chemotherapy agents more, we'll be able to target it and say, okay, we're just going to kill liver cells, or we're just going to kill lung cells, or we're going to just kill ovarian cells. And so you won't have all the side effects you have.
How it affects the different parts of the body. It was really interesting because when they talked about over 100 chemotherapies to treat cancer, and then, it was just talking about how, the physician, your physician specialist needs to decide like how much to use and how much not to use. It could be dangerous if you use too much. And if you use too little, it might not work. So that's really interesting. That's called precision medicine, right?
Yeah.
Because you have to be really precise to know what type of treatments and how much chemo people should get. Because some people, they get it and they're not as sick as others. And some people just become really, really sick from it, Dr. Izard. And that's because their body probably reacts a little different than some others.
Right. Because there's certain things, anytime you give a medication, you have enzymes in your body that break that down. Okay. And that's how you prevent yourself from getting poisoned by, anything you eat. But some people might have exceptionally high levels of a certain enzyme that might break down certain medications, or some people might have low amounts of a certain enzyme that breaks down medications. And because of that, you give someone a medication and someone's they're going to respond to it less than you would expect, because again, they're rapid metabolizers of that medication. So they need a higher dose, or someone may be a slow metabolizer, and so they break it down slowly. And so you give them the dose you normally give somebody else, and it's too much for them. So yeah, all that it goes back to your genetic type.
And it's so interesting when you start looking at why do you want to have such a large database? And the reason for that is that the more people we have in a database, the more kinds of different things we're able to identify in individuals. For example, they were looking at the DNA data for more than 245,000 all of us participants, and they found 14 people who had the alternative DPYD gene variant, but not the active variant. And so, Dr. Izard, they're saying that you might have something, but yet and still it's not active.
Yeah.
When they're talking about something like
that.
So
I think that the point that you're making is that diversity. This is why diversity is important, because when you have a small number of people, let's say we have 100 people, and some of these studies you see, maybe 100 people had this medication and this is how they responded to it, and we kind of generalize. 100 people is not a lot of people, so especially depending if you were doing like this in an office-based thing, and so you took a doctor took 100 of his patients and they tried them with this medication, and then took 100 and put those patients and put them on a different medication and compared the two. Well, there's a bias in the patients, a selection bias. So the people that were in his office may tend to be white. They may tend to be healthy. They may tend to have a certain insurance. They may tend to live in a certain area. So you need to have large numbers, thousands, millions of people in these studies a lot of times to get enough what they call power to be able to to draw a conclusion. So you have to have diverse people in these studies, because some of these things, especially with new medications, you don't see some rare side effects. Let's say a side effect happens to 1 in a million people, and you've only tested it in 100,000 people. Well, there's a good chance you're not going to see that 1 in a million side effect until you start having 20 million people on it, and then you start saying, oh, people are having brain bleeds, or other things that are going on that you wouldn't have seen with a smaller number of people.
And what was so interesting about this study is that in response to the study, as experts changed the guidelines that providers followed the PDYD gene testing for chemotherapy use. So the guideline now recommends that labs test directly for the active P to DPYD gene variant. And so, what's so interesting is that they realized through the study that there needs to be more before we start looking at how we want to treat people. Dr. Izard, it looks like we're going to take a quick break. We're going to see you on the other side.
We'll be back to rock your mind with more facts.
Yeah, we welcome people to call us if you want to sit at the table with us this morning at 414-444-5250. And if you have any questions, please give us a call. We have our doctor here that will be able to have conversation with you. We'll see you on the other side. Welcome everybody back. This is Kara Dotson, the program director for the All of Us Research Program at the Medical College of Wisconsin. And I have my favorite doctor with me. Good morning, doctor.
Good morning. Good morning, everybody. Grab your coffee. Pull up to the table.
Yeah, Dr. Kevin Izard is here. And we have been talking about research. And I think that it's been very important for us to share this information with you, because now you can see the results of what's really happening, because people are participating
Mm-hmm.
in the research. And as we kind of move forward in this process, we're getting close to, we have over 600,000 individuals that actually have contributed their biosamples,
Mm-hmm.
and we have over 800,000 people that have signed up already.
Right.
So that's a lot.
Yeah.
You know,
and the goal is to get 1,000,000 though.
The goal is to get 1,000,000, so we're getting close. But
Yeah.
we want to make sure that you also are involved in research. If you choose not to be involved with our program, there are other programs that you can be involved with. So you can talk to your doctor about it.
Mhm.
And you can go also on the websites, like I know the medical college, they do have information related to research programs that are happening right here in Milwaukee as well.
Yeah. Now, unfortunately, when you sign up for all of us, you don't know which studies that your dad's been used for. So what they do is they depersonalize it. They de-identify your information. So when you give your urine and your blood samples and your information, it goes into the database, but they take your individual information out of it. So no one can go back and find you, say, oh, this person had an interesting finding. I need to go back and I want to see this person. It doesn't work that way. They can't identify you individually, and that's part of the security measures.
Right, and that is still in place, and we're happy to say that it's been working very well.
Mm-hmm.
Doctor, we were looking at it. We had some conversation about this artificial intelligence, as far as how that's starting to work in science and research.
Mm-hmm.
And you hear so many things about it, you kind of get a little worried, because this is like the next level.
It is
of what's going on. And so just wanted to have you talk a little bit about what's going on there.
I remember back in the 60s and 70s, it was this fear of computers are going to be able to, this intelligence was going to come over and take over. Well, now this is the next step. Now it's this artificial, not just computers, but it's this artificial intelligence, the programming that people are more concerned about, and rightfully we should be concerned about computers making decisions for us, and we become more dependent on computers and machines to take care of us. But also, just like having computers, it's revolutionized the way we do things. I mean, I remember back when I was a kid, if you had a question about something, you would call the library, or go to the library, and you'd have to go to the card catalog, and you'd have to find the book, and get off the shelf. And now you can find way more. We have encyclopedias.
I know, right?
And encyclopedias are just a few thousand pages of information. You look up something, aardvark, there may be a paragraph on it. You can now go online. You can find out way more information in your pocket, in your little phone, which we call it a phone, but really it's a little personal computer. All that stuff is right at your fingertips. And so, the next step, what's going to happen is that you're going to be able to use this in more useful ways. So you can, even now, you can ask Chat GPT, tell me about what are new medications in diabetes, and it will go through. It'll go online. It will find the stuff, and it'll Google search and come back to you with a summary. You can have it summarized and with bullet points, or you can have it compare compare this medication versus that medication, and it'll tell you all that stuff. So there we're getting to the point there's almost no excuse not to avail yourself of the right information. So we hear something that sounds crazy, it sounds too good to be true, or it sounds too bizarre to be true, look it up.
Yeah, but I do have a question for you, because a lot of times when I'm going in to see my doctor, I might look certain things up, and I've had other people say that too. And sometimes we try to diagnose ourselves.
Right.
And so we have to be very careful with the information that we read.
That's true.
That how we react to it. I would say what I do is that I share the information with my doctor, and he'll say, oh, no, Karen. Or he'll say, yeah, you're right on target. Right. But, so that helps,
right.
You make some decisions as well.
But when I say look it up, when you go into the doctor, you should have I mean, if you think you have something, you should have some ideas of questions you want to ask. So a lot of times people leave the office, they don't ask any questions, and then they get home and then they start making stuff up because they didn't understand what the doctor said, or the doctor never told them. So you need to have your questions. And if someone says, I'm putting in this medication, or we're going to do this treatment, or we're not going to do this treatment, you should have some understanding as to why they have that rationale. And so that's why you go to medical school, is because you're learning how to take the raw data. Okay, someone has this symptom and this symptom and this symptom. And then the training is to figure out, okay, what's most likely the outcome of this, or the diagnosis of this, and what's the best treatment for it. Now with medicine, that changes. So things that we thought, like, boy, back when I was in school, it was just at the point where we're learning that ulcers were caused by bacteria. We used to think that it was caused by type A personality. So people who were stressed, they would get ulcers. And there was a doctor who was saying, no, I think it's caused by a bacteria. And people said, no, it can't be, because the pH in the stomach is 3. That's way too acidic for bacteria to live. And so, they did research, and guess what? They found that, yes, there is a bacteria, Helicobacter pylori, that's able to live in the high acidic environment of the stomach. And people who have H. pylori, the H. pylori bacteria, and who have ulcers, if you treat the bacteria, the ulcers go away. Now, everybody with ulcers has a bacteria, and everyone with the bacteria has ulcers, but if people have both, you treat the bacteria and the ulcers go away. We didn't know that. And
so how do you know it now? How would you have to get a special test to find out if you have that bacteria?
Yeah. So back in the, in the days, like, back when I was in school 25 years ago, what they would do was they would do a biopsy. So they would do they'd go into your stomach and they take a sample of the tissue, send it off to the lab, culture it. Okay. Very invasive, because you gotta go down into your throat, into your stomach to get the sample. Well, then they started doing DNA tests. So they said, oh, okay, so looking for your immune system. Has your immune system been exposed to the bacteria? Well, now they got even better tests, and this is really freaky. So what they can do is, what we'll do now, if we suspect someone has this H. pylori bacteria, we know that the bacteria will ferment this this chemical called citrate. And so what you would do is a breath test now. So we give people a bag. They breathe in a little sample of air from their breath into a bag. We have them drink the citrate, and then 15 minutes later, we have them breathe into another bag. And so they can measure the difference between the fermented gas and the before sample and the after sample. So you can tell if someone has H. pylori based on the gas. It's really
and I always wonder too, like sometimes when you have, and I don't want to sound like this is weird, but you can also, can you tell like when people might have some kind of health related issues by their breath?
You can. I mean, and I'm sure there are people that that are far more adept at than I am, but yeah, you can tell things like for instance, I can tell if someone has a sinus infection because their breath will be bad.
Really?
Yeah.
Wow.
Yeah. So there's a lot of things that that we don't, little subtle things that, and we kind of got away from it now because we're a lot more reliant on technology. But back in the old days, boy, people would just based on a physical exam, they'd be able to, like, even diabetes back in the back in the day, the way they diagnosed diabetes. Okay, so we know about type 1 and type 2 diabetes. That's diabetes mellitus, and mellitus means sweet. And I'll tell you why that's relevant. There's another kind of diabetes called diabetes insipidus, which is far rarer, and it's also a problem. All they knew was that back 150 years ago, they knew that people would start peeing a lot, and then they would die soon after that. Well, what they would do, the doctor would take a urine sample and stick his finger in it and taste the urine.
Oh my God!
I know, right? If the urine tasted sweet, it was diabetes mellitus. If the diabetes was tasteless, it was diabetes insipidus.
I wonder how many doctors died behind that.
But see, they were dedicated to their
Obviously, I mean, that's like nowadays we know better, but that's
Yeah.
interesting how medicine has really like moved to
Yeah.
a whole higher level.
Yeah.
And so now we're looking at this artificial intelligence.
Right.
And when like you hear so much about this, it's almost like this is like trying to take over,
Mhm.
the
Yeah.
mindset of people.
Right.
But
some good things have come out. Like for instance, one of the outcomes of with all this projects was making a connection between diabetes and thyroid disease. And so you're able, what artificial intelligence is able to do is able to take large numbers of amounts of data and see connections that it would take people a long time, if ever, to see. And so it can take 1 million people and all of us and look at go scour all that data and look at, okay, make the connection between this disease and this genotype and this other disease. So they can it can see that. So all artificial intelligence is in the future is going to play a lot bigger role. Now the question is going to be, for a while IBM has had this project going called Dr. Watson, and so they're trying to figure out if people can use artificial intelligence to make a diagnosis. And so so you put your symptoms in, and Dr. Watson should be able to tell you, okay, you likely have a sinus infection and you need antibiotics, or you have a sinus infection and you don't need antibiotics because the data says that that within 5 days you're going to get better without antibiotics. So the problem I think with that is that medicine is one of these areas still where a lot of people getting better has to do with what we call laying on hands. You touch somebody and that actually helps them get better. You listen to them, there's sympathy. If people believe the medication you're giving works, it's more likely to work. So there's a whole big component.
Mindset,
yeah, right. The whole big component that you're not going to get from a computer spitting out a diagnosis. There's still a lot of, there's an art to medicine, still more than just or as much as a science.
And the other thing, when I was reading about artificial intelligence, is that it allows for researchers and physicians to find different ways to use existing medicines too.
Mm-hmm.
So they look at the combination of what really happens, and it really kind of gives researchers an idea of maybe how to proceed with some new research or do some other checking.
We haven't gotten here yet, but the goal is to be able to take a medication and because right now they have to experiment on animals, have to experiment on people, see the effects. One day you'll be able to just take a medication, put the structure of the medication into the computer, and then it will be able to predict what effect that's going to have. Because right now, what they do is they're like going into Amazon and they're testing plants and trying to find different things that may have some effect, and then they refine it and they try to, that's how they find these new medications. But one day they'll be able to say, okay, based on this protein, and proteins are really, so proteins are chains of amino acids, and these amino acids fold up and they form this big protein, this big ball. Okay, and each protein has its own structure, and because of that, it makes it, that's how it interacts with other different things. So for instance, your immune system, your immunoglobulins are proteins, and they fold in a different way, and depending on how that protein folds, it's going to be sensitive to the flu. And so when it comes in contact, and this is an amazing thing too, is that, so the way this protein folds, actually is just the end of that protein, the way it folds makes it sensitive to flu. So if flu is flowing through your bloodstream, this amino acid or this protein, this immunoglobulin, is going to see it and it's going to be attracted to it, and then it activates a bunch of other things. So it's all these folding of proteins, and again, it's extremely complex. But with AI, they'll be able to figure out how these proteins are gonna fold, and they can even try to retro engineer medications based on illnesses or based on things that are you might come in contact, infections, um, by figuring out this medication is going to do this or this medication is going to do that, or even your own personal genotype. So yeah, there's a whole lot of precision stuff that's out there still yet to even be tapped.
And that's really kind of interesting when we start looking at how technology is moving to a higher level. It makes me feel good that we're in a time now that we can get some more precise answers and not always in the guessing game.
Right.
Because I used to always think about how many medications I and along with others have taken and family members. And they're like, well, my doctor said I'll take this. And if this doesn't work, then I'm going to try that.
Right.
But wouldn't it be great that, we have our system set up for precision medicine like we do with our glasses, where we can go in and get personalized health care. And it's for you, just like your glasses, Dr. Izard, that you wear are going to be different than the ones that I wear.
Right.
They're made for you.
Right.
Wouldn't it be great that all our treatment is made directly for us?
Right. Yes, because sometimes people will be prescribed something and someone will say, don't take that. When I took that and this happened to me. And that may not be the case, or take this, the doctor gave me this right here and this helped my situation. Maybe your situation is different, or maybe you're different, and so, so we're going to get more precise. And I said, I'm excited about this, be able to, so maybe they can even bypass having to use animal models anymore, because they can do a computer model to predict what effect this drug A, this new drug, is going to have on the human body.
Wow. I mean, that's going to be remarkable. So as we continue to look at precision medicine, as we continue to look at research, one thing that people can do is that you can always Google to see exactly. You can go to joinallofus.org and look to see what types of research is going on. But you can also just Google and say, like, what type of research is going on for this type of illness, and see what's out there as well. Because
you can still be in those studies, like, for instance, if, someone in your family has a cancer, like breast cancer, oftentimes, the doctor will recommend that person have their family members, especially the females, be tested for certain genes, like the BRCA gene. And so, so some of that is already, being done without people realizing, what it really is. When you go to genetic counseling, that's really what they're looking at. They're trying to figure out, do you have a gene? Are you predisposed to this? And so some women will decide, if they have, that BRCA gene, they might decide, okay, I'm at increased risk. My risk for having ovarian cancer, and or breast cancer is a certain level. I could either get tested every 6 months, or I could just go ahead and just have a hysterectomy and then not worry about it.
And some people actually take those types of choice. They make those decisions.
Well, you have a mastectomy.
Because especially if they see some of their family members going through some of those major challenges, and they know that the probability is high, they've taken some of those. They have made some of those decisions for their health. Yeah,
they can even do now. We're at the point now where they can, like, I have a patient who has Huntington's disease. It's a kind of a rare neuromuscular disease. So he had his children tested. Well, actually, his sister had it first, and we found out that he has it. So he got his daughters tested, and one of them has it and one doesn't. So the daughter just got married not too long ago. So they're able to screen her eggs to see which of them have the gene. And so they can actually decide, if someone has a genetic disorder, they can actually screen out those eggs that have that genetic problem and just use the healthy eggs. So you can eliminate passing on that disorder to the next generation.
That is so, that's just wonderful news to hear, how, making those decisions allows for us to, knowledge is power, and the more that we know.
But the other thing too is, though, we got to be careful, because, that's, it's kind of we're starting to tread into this eugenics now, this idea of having the ideal genotype, genes. And so, we start talking about screening infants, so maybe you want to screen infants. You just want to have babies that are going to be 6 feet or taller, or you
Wow.
might just want to have kids that have blue eyes, or,
Oh my goodness.
So yeah, that's where the ethics come in. And so, even with all of us, ethics is a huge part of this. We make
Yes,
sure that
yes.
these things are being done ethically, because it's easy to take advantage of people, um, who otherwise, have been either powerless or don't have the information, and so you end up with the Henrietta Lacks situation, where she had this rare cancer that continued to her cells kept reproducing. They used her cells. They did all kinds of research and the technological advances that came out of her cells, but no one ever told her or her family what they were doing. So the ethics part of is a huge part of this, and that's, again, when you do enroll in all of us, that's one of the things they spend a lot of time making sure you understand how your information is being used. Getting what we call consent. You want to get make sure people understand the ramifications of giving their blood and their urine.
Okay. We are going to also be talking with some individuals that are really involved in a wonderful research program, and it's called Autism Spectrum Disorders. Um, that we will be talking with them shortly. We When I was looking at autism spectrum disorders, and Dr. Izard, you really brought this to our attention that these are some individuals that we definitely want to talk to.
Yeah. So autism, is most of us knew, maybe when I remember when I was a kid, there was that one boy, Ricky, who the teacher that always sit with him because he would shake his hands, and he was just, we knew something wasn't right with him. And that's got more of a severe form of autism. But now we're acknowledged that there's a spectrum. So there are people who are very functional who might have autism. They have problems with processing social cues. So otherwise, they're very smart, but they have problems with, being able to, to identify, like, for instance, if someone's happy, if someone's sad, if someone's, making subtle gestures for them, they might not be able to pick up those cues. And so we're starting to see more kids diagnose more kids with autism. Now, like, speaking of research, we don't know why that is. We don't know if we're just doing a better job at identifying people, or if there's actually an increase in the number of kids with autism. Um, so when we come back, we're going to talk with a couple of parents who have children, young adults with autism, and
actually someone that's been doing a lot of research with
on
it
it.
as well.
Yeah.
I mean, I'm excited about Elizabeth, Dr. I should say, Elizabeth Dane joining us, along with Veronica Real, Nolan, and also Tyra Adams. And so we will see people on the other side to have this discussion. This is going to be a great discussion too, because this autism spectrum disorders, when you start looking at when to detect those individuals, it's really early in the age, Dr. Izard, right?
Yeah, and that's part of the challenge too, is for us primary care doctors to try to identify kids early on. And so you can tell some things like a baby. A baby should be able to, at a certain age, be able to look in your face and track. And so you start seeing that some of these kids with autism, they're missing those early cues where they're not looking at your face. They don't react when you smile. When a mother smiles at a baby, the baby should react to that. And we're seeing some. So we're trying to figure out earlier on, what who has autism, and then we can get them, in therapy and things earlier on. And also just what do you do with these kids when they become adults?
Right, exactly. So Dr. Elizabeth will be joining us, and we'll see you back on the other side.
Every time we hear the music and we're in this love.
I want to welcome everybody back. This is Karen Dotson from the Medical College of Wisconsin, the program director for the All of Us Research Program. And I have some wonderful guests with us today. It has been quite an interesting topic for us. And Dr. Elizabeth Drame is on as far as being able to tell us more about autism spectrum disorders. Good morning. Good morning, Dr. Liz.
Good morning. How are you?
I'm good. It's so great that we were able to get you. We've been waiting and having back and forth conversations on email. And so this is great to be able to have you. We also have Tyra Adams joining us today too, has been a part of the research that I want to just briefly introduce you all, and then we can kind of go from there. Dr. Elizabeth Drame is a professor in the Department of Teaching and Learning at the University of Wisconsin-Milwaukee, where she prepares special educators and coordinators the Autism Spectrum Disorder Certificate Program. Research and practice endeavors focus on issues of equity and social justice for individuals with disabilities and involve the practical application of collaborative participatory research to community-based equity challenges in local, regional, international educational contexts. Dr. Drame is a Black aunt to a biracial artistic niece. It is delighted to have you on today to talk about this, because a lot of times we kind of keep this quiet in some of our families and our communities. Is that correct, Dr. Liz?
Yes, I think that I think it's getting less and less like that. I think, can you hear?
Yeah.
Okay. I think it's getting less and less like that. There's less and less shame or, desire to kind of hide, because there's more understanding, I think, about what autism is. But I think it's something that, just any kind of mental condition or cognitive condition can be, for various reasons, difficult for parents to accept. But I think it's getting more and more with increased understanding and awareness. People are willing to walk into understanding what it means to be autistic and to live with autism.
Can you give us a definition of what is autism spectrum disorders?
Sure. Autism spectrum disorders it's a neurodevelopmental condition that affects how people interact with others and how they communicate and behave and learn. And you notice I'm not saying that it's a problematic thing. It's actually a condition that influences how our brain perceives the world, and our brain is our engine, right? It controls everything we do, and it's called neurodevelopmental disorder because the conditions or the symptoms or the signs of autism generally appear in the first couple of years of life, whether it's diagnosed within 2 years or not. So it's we've had some changes in how it's defined and diagnosed. And so now, under the diagnostic statistical criteria, that's the most recent criteria, you're supposed to have two different categories of signs. So one is social communication and interaction. So you're supposed to have challenges or exhibit challenges in understanding different social cues, how to engage in reciprocal dialogue or conversation, and how you express your needs. And then there's another category of behaviors where it's called restricted and repetitive behaviors. And so individuals typically show like a need for routine, sometimes a real focus on specific interests. Sometimes they use repetitive movements to self-regulate and soothe. And then in this criteria, there's different levels of I guess, severity, if you want to call it, or different levels of needs. And so that's, that's partially how within the category of autism spectrum disorders, it's a spectrum. So that means people with autism are going to have unique profiles of strengths and challenges and areas that they need different support. And so it's hard to pigeonhole, because, you know, people say one person with autism. If you know one person with autism, you know one person with autism, because, you know, how their different needs and supports and gifts and talents are expressed is going to vary
You
from
know,
one person to
Doctor,
the next.
when I was reading this, I was also noticing your baby could be fine up to like 6 months or a year, and then they might start regressing some.
Uh,
Is that true? Or, you know, can you kind of let me know, like, how can a person really start noticing that your child has some of those challenges?
uh, Collaborator to join.
Okay, Dr. Liz, it looks like you're kind of breaking up there, so I'm thinking we might have some connection issues. Yeah. Okay.
Okay, so could you ask your question again?
Yeah, I was asking, when you have your child and they're an infant, it looks like they kind of go through and they seem normal. And I say normal meaning, like, you know, don't have any type of learning disabilities or challenges. And then all of a sudden you start noticing like they might start regressing in certain areas. Is that true?
Uh, so here's the thing with memory, right? I'm not going to um, question parents' memories, but a lot of times parents will say, my child was talking and then they stopped talking, or my child was, you know, interacting with me and then they stopped, and sometimes they identify some kind of critical moment where that changed, something happened and then that changed. And I don't have any explanation for that. I think most individuals who are diagnosed with autism, the diagnostic process is not, there's no blood test, there's no brain test, there's no genetic test. So what is done to identify autism is different scales that parents fill out. You assess language, you assess cognition, you assess interaction and how individuals engage in play situations. So there's these kind of diagnostic assessments, but they're not, you know, so a lot of it can sometimes is based on what people remember. So most of the times you're going to remember things that you might have thought about it, or something doesn't seem like it's, you know, going the way it should go, and then but you have an explanation for it, and then as the child grows and develops and then they end up having a diagnosis, you look back and at those behaviors a little differently.
Okay. Thank you for that explanation on that. We also have a couple of individuals that you have worked with in the past, and I think you still do actually have worked with them. We have Tyra Adams. She is a proud mother of two Black young men, one of whom is artistic. She has conducted participatory community-based research published in the book. And this is a book that you all have worked on together, The Resistance, Persistence, and Resilience of Black Families Raising Children with Autism, by Peter Lang Publishers. She is currently a co-researcher on a research study founded by the Spencer Foundation, Cultivating Black Artistic Youth Agency in the Context of Police Encounters in Schools and Communities. And then also, it's great to see that we have Veronica Nolan. She is a proud mother of two Black artistic children. She conducts an advocacy work in the Milwaukee community and beyond, supporting families to grow their capacity and advocacy skills. She has conducted participatory community-based research published in the book, the same book, that I mentioned earlier. She is currently a co-researcher on research study founded by the Spencer Foundation and also cultivating Black artistic youth agency in the contents of police encounters in schools and communities. And I want to say welcome, ladies. Welcome to being at the table with us. I'm so delighted to see that you were able to join us. And thank you for wanting to share some of your story as well.
Yeah.
And so there's some experience that you have because you are right there relatable to what we're talking about today. And so I want to first start with Tyra. And Tyra, welcome sitting at the table with us today.
Thank you.
Can you kind of give us an idea of how you've been involved in this research project?
Well, I've been involved, first of all, as I do have a 24-year-old son with autism. Um, I've been involved because I wanted a better life for him. And so you have to be involved when you see those differences. I don't like to say not normal, but when there's differences, you have to be involved. And me being involved is also the need to help others understand what's going on with children or how to help them communicate.
You know, Tyra, I appreciate you for saying that you don't want to say not normal because what is normal, right? And I
Right,
think that's what we've all questioned because a normal can be normal in different ways and capacities. So
right.
thanks for that correction on that.
Mhm.
But also, Veronica, can you let us know exactly how you've been involved as well?
Well, good morning, and thank you for
Good
having us.
morning.
um, so I've been involved, well, since Brandon was, and he's my 21-year-old. He'll be 22 this year, and then with Brianka, she's 11. I've been involved since Brandon was about 3 years old. Um, I'm one of the co-founders of the Urban Autism Summit that went on for several years. It's not being conducted at the moment, but I'm hoping that it can get, started up again. But it just I just when I see a parent in the same shoes that I was in years before, I immediately jump into action and want to help, without actually stepping on their shoes or stepping on their toes or being insulting. But I'm always like, oh my God, I just want to help them. I just want to give them information. I just want to inform them of different things that are going on. And also, I'm out there and I'm willing to learn as well because things are changing. Things are different now from when my son was, younger. So there's, different terminology, different ways of doing things. The waiting list for getting on the children's waiver is different. And so it's always give and take. And I'm always willing to learn and always willing to help. So.
So why is it important to include Black parents as researchers and not just subjects in research?
Well, I think it's important because I feel like hands-on lived experience is just as important as the studies are, and we are actually the expert because we know our child. And I wanted to say too, as far as it being a research, I don't consider my information as my child being the subject. This is the life, and I'm just trying to explain to others what happens, what to expect, what to do as much as I can.
Okay.
Yeah.
I would
So
like to go
I would love to talk a little bit about this too, and I think Veronica as
please,
well. This
please.
is really important because I think there's this idea of whose knowledge counts and matters. And when you go to school and you have all these different degrees, that does give you some greater understanding. But when you're trying to do research that is going to positively impact specific communities, and you don't include the individuals in those communities as like equal partners in that research, then it's very easy, I think, to ask the wrong questions, interpret data in ways that are not helpful, come up with the wrong recommendations. And so, this idea of, yes, we need more Black people to be participants in research, but we also need the individuals who are going to be impacted most by the research findings to be part of being the researchers, right? And being totally engaged in identifying the solutions to the problems that we're trying to have and answers to. And I think that's why this idea of doing participatory research is really important. I don't know, Veronica, if you want to add a little bit more to that.
Please, thank you.
Yeah, no, I just it's important to me individually, and I'm sure it's important to other families to see someone who looks like them doing the research, and rather than just, a different face, a different color, not being who they would expect, or being who they would expect. We're different from what they expect, because normally the research is conducted by not us. And so with it being us, I feel like it helps the families, the individuals, to be more willing to participate, be more willing to be part of this research, and to help us conduct a study that will not only help our children and adults, but also help theirs and others in the community, and even not even just with autism, but with other different abilities as well.
You all have shared a book with me that you have published, and I would like for you to talk a little bit more about this book, how it came about, what were some of the findings in the book, and how can this help others?
Well, originally the book started out with us doing an interview with a local station, and the interview, it took us all day to film and to do the interviews, because we all did separate interviews, and then we did interviews together. It took an entire day, but the segment ended up being like 6 minutes or less, and it didn't really touch on all of the things that we really thought were super important to reach our audience, or reach the audience. And so it just, and this is just my point of view, it just came about where we just felt like, well, what do we do? How do we get our information out there, and this information that we've learned and gained over the years just from our own experience, out to other families, to help them along the way and in their journey, in their individual journeys. And so, Liz, do you want to go from there?
Yeah. That was like the springboard to us having these kitchen table conversations. We started to meet every other week around the kitchen table, just trying to answer questions and about their experiences. And I was more like a facilitator, because I am a researcher. So, so I started to say, well, we're having these conversations, we're coming up with these powerful, ideas. How do we get it out there? And as a researcher, I was like, let's do research, right? And so they were like, what you mean? What do you do? So then we started to do more structured conversations around the kitchen table. And then as a researcher, you don't want the situations that you're talking about to be identifiable. So then we started to realize, well, we need to talk to other families. And so that led us to doing the formal process of getting human subjects approval from UWM, and reaching out nationwide to Black parents to talk to them about their experiences. And Veronica and Tara were like right there we were all researching together, collecting data, conducting interviews, doing analysis, doing interpretation, doing writing, and all of that. And it took several years, but we captured initially the idea was to have a journal article, but then I was like, who's that going to reach, right? Journal articles reach a very small segment of the population, maybe, and it's not families. And they were really interested in making sure that families could access this information too. So we ended up saying, let's do a book. And then that was a challenge, getting the book published, because publishers that we were interacting with did not want Tara and Veronica to be co-authors, even though they were co-authors. They were co-researchers. This book wouldn't exist without them, because they were, they didn't have the PhD behind their names, right? So they were like, they could be contributing authors. I'm like, they're not contributing authors. They're co-authors, co-researchers, co-authors, co-everything. And so we almost gave up at that point and started to say, we'll just self-publish. And then a publisher reached out to us, Peter Lang. And I don't know how maybe one of the other publishers who disagreed with the editorial decisions reached out to someone, to Peter Lang, to say, look, this is a project that you wanna publish. And so then it was published through Peter Lang, and we were very grateful that, yeah, so that was a very interesting process.
I just want to say that my son is in the next room. I tried to find a space where it's quiet, and you're going to hear him humming and being loud, but that he's part of the interview, I guess.
Wow. Okay. Well, that's real life experiences that that you're sharing with us. So we appreciate it, Veronica.
Sure.
Because
And
this is your life. This is your life.
It is.
Yes. We're going to take a quick break, you all, and we're going to come back on the other side. I'm talking with Dr. Elizabeth Drain and also Tara Adams and Veronica Nolden. We are talking about autism spectrum disorders, and they wrote a book that they'll be talking more about, and also just talking about some of their findings in that. This is Karen Dotson from the Medical College of Wisconsin. We're at the table today, and we're looking forward to coming back on the other side to give you more information.
Greater One Community Center offers a free health clinic addressing health inequity. It's like a diamond ring, it's precious.
I want to welcome everybody back. This is Karen Dotson, and we're at the table today. I'm from the Medical College of Wisconsin, and we have Dr. Elizabeth Dre May. I hope I pronounced it right. Did I pronounce it right?
It's
Drame.
Drame.
Okay. Drame. I didn't ask you that yesterday when I was talking, and I was like, so I thank you for that correction because we want to make sure. Can you pronounce it one more time for me, Elizabeth? Drame.
Drame.
Dr. Drame. And she is really doing a lot of research related to autism spectrum disorders. We want to welcome her along with Tyra Adams and Veronica Nolden. They are actually mothers of individuals that are challenged with this, and they are here to talk about the book that they have worked along with Dr. Elizabeth on. And I wanted just to ask, when you wrote the book and you went through, because I really appreciate, Dr. Elizabeth, how you walked us through the process as far as how you were, really just starting to have these table talks or these kitchen talks you mentioned with individuals. And then after that, you kind of looked at, let's do something with this. This can be something that we can move forward on. And that through your persistency, you were able then to get a book with you along with the other two young ladies. And can you talk about, because you mentioned that you reached out more on a national level as well. So it sounds like you really did your research to bring it all together. Can you give me some discussion on that?
Sure. And Tara, I know you wanted to jump in before, so I'll talk and then you can jump in. So I just want to say that I was being pushed, like these ladies, and there was a couple of other mothers at the time that were with us as well. And one of them is a co-author, Judy Nardi. And I was being pushed as a researcher, right? Because as a professor, you publish your research. That's part of what you do. But I was being pushed to do more. I was being pushed to make the research that I was engaged in impactful and meaningful in some way. And so Tara and Veronica were like, okay, well, we know what we've experienced. Are other families experiencing the same thing? So they started with, saying, let's talk to people that we know in the community in Milwaukee. Let's engage people that we know. And then I started to talk to people that I know. And it became this kind of snowballing effect. So we talked to one parent, and then they wanted us to talk to another parent and another parent and another parent. And so everything was really organic. And I think that's the case with participatory research, because you're not coming in with an idea and a predetermined way that you're going to do things. It's kind of collaboratively defined and designed with your partners. And it's also influenced by the people that you talk to as well, too, the people that you actually engage in research. So that was the other piece, too, that was really, really cool, is that there was relationships being, developed through the interview process with new mothers, and Tara and Veronica.
I was just
Tara, did you want to jump in?
It was easy to do this because we were trying to help our children. But what made it easier is that at one point, you felt like you were alone in this. And then we found Veronica and Liz. I thank God for those two are great. And as we thinking that sometimes you're in a situation alone, talking to others, and hearing their struggles or challenges just made it easier and you're more interested in it, especially when you're doing it with good people.
Mm-hmm. Mm-hmm.
Okay,
And
Veronica, do you have something to add?
Yeah, I just want to say a lot of the challenges is not like necessarily our children and other parents' children. The challenge is society not accepting our children and not accepting the different ways that our children walk, talk, eat, breathe, sleep, communicate, And that's the big challenge, at least definitely for me. Staring at them and doing things that um, I feel, and I know that my son and my daughter, well, my son is limited verbally, but my daughter, she's very verbal. But when someone is staring at my son, I feel like he knows this. He's feeling it. He's not numb. He's not oblivious. So I always make it a point to make sure that they know that that's not okay. I don't know if I think it just went off to the left with that, but but that's
I think
the
you're right. I think
challenge.
that's really great
Is
what you're saying there. The people
yeah,
should be mindful that they have feelings too.
yeah,
They can
exactly.
express those things.
Mm-hmm. Absolutely.
I have a question for you all. Kind of walk me through the process. Like when when a mom or when parents identify that their child might be having some challenges, can you walk through like the process of what you have to do and your journey? Can you just kind of take us through it a little bit?
Okay, I'll go first. So I have a niece. She's about 4 months and 11 days older than my son. And so she was, doing things that, I wasn't, it was a first child in our family between myself and my sister. And she was doing things, walking, talking, feeding herself, doing all these different things at like 10 months and 11 months and 12 months. And when my son became, got to that age, I noticed that he was not doing those things, that he wasn't having any and at the time I didn't realize he wasn't having eye contact with us. I wasn't aware of what I was looking for. But I was just noticing that he wasn't walking and he wasn't talking and he wasn't babbling and he crawled very late. It was just a lot of things that I was like, that's just, that's different. I wonder what's going on here. And so we went through the whole process of birth to three. We went through the whole process of, well, first we talked to the doctor, and then he referred us to birth to three. And then just seeing the different providers, being told by one provider at one point that my son was just constipated. That's why he's walking on his tippy toes, because walking on tippy toes is one of the signs of autism, as well as, no eye contact, no communication, at least verbally. And so just going through that was challenging. And so it was actually the teacher at the school at the time when Brandon was going to school, and the school psychologist, who pushed me and encouraged me, because at first when they told me that he doesn't have autism, that he had pervasive developmental disorder not otherwise specified, PDD-NOS, when they said that that's what he had, I was like, oh, okay, well, this is simple. We can rectify this. It's okay. We'll be able to handle whatever's going on here. And but when they told me, they said, no, that's not what it is. He has autism. He has classic autism. And so I said, okay. Because there was two people telling me something different from the doctor. I don't always listen to the doctors because I feel like they have their point of view, but like Tara said earlier, we know our children, and our PhD might not be behind our names, but we have a PhD in our children. That's Tara's line. She says that all the time. And so just having to go through all those steps, it was really sad, but at the same time, having that support was really encouraging, and I'm so glad that I did follow those ladies' suggestion with getting my son officially diagnosed and getting him the services that he needed specifically for autism, and not just a general therapy for speech and things like that.
Okay. Tira, can you walk us through?
My journey was, so I have another son who is almost 7 years older than Kobe, and he was very advanced and talking at 2 and writing and all that stuff. So as Kobe was not doing it, I um, started to notice that. But I felt, as a mother, all kids learn at different ages, and he's gonna zap into it. But then in the interim, you were hearing people in the background, which is very hurtful, and people should really think about this when you're saying things about these kids. They're not walking, and they can't do this, and they can't do that. That's very hurtful, and then you don't even know the reason why. So that was another part that was hurtful. And when I took him to the doctor, you have to take them to doctors that know about these different things, because as I was telling my doctor that something's different, it's not this, and she would just say what I wanted to hear. um and I felt that. I told her one day, I thought I'm just going to pray hard enough and we were going to wake up the next morning and he would be on task. That didn't happen. But she was refusing to me to get him diagnosed. So after he did, he was almost 6. Yeah, just about 6. And then it took 2 years to for him on the to get on the for the waiting list. But the journey was very
When you say
difficult
waiting list, what do you mean by a waiting list?
to get ABA therapy.
Okay. Okay.
um and then during those years nobody tells you what to do. And actually when my son was diagnosed, I had never ever heard of the term autism. I know anything about it, nor did the doctor try to explain it. So then I went to googling and researching. That takes you to all kind of different things and emotions. So it was a very difficult journey, which I didn't think at that time that I would see the light at the end of towards the end of the tunnel like I do now.
Mm-hmm.
But a lot of it, and it still is, sometimes I think people need to be aware, and it's not so much the youth, it's the adults that look and form opinions and say things to the things. So uh, it's a pretty rough journey, but I'm glad I stuck it out because it's all worth it.
So, are there any? I want to just ask all three of you ladies: are there any support groups for parents that are dealing with autistic children?
Well, we used to be me and Veronica. And Veronica, that's how I met with her. Through Wisconsin Facets. Um, she was over the urban autism disability program. When she got pregnant with her uh, second child, she was over the urban autism support group. And once she got pregnant with her child, could no longer do it, she threw me under the bus. So there I went, and we
You under
had.
the bus?
Well, I mean, I wasn't ready for it. I was still trying to learn. I had no confidence.
She dropped you like a hot potato.
Yeah. And I was like, what? All I said was, okay. What had happened was one of those things. But then, I mean, it started there as a support group. And so we were doing it, and eventually that funding and stuff went through for the urban autism group. There were other groups that was going on, but that funding fell through for that. And we just started, that's when we all met and started talking with Liz and doing our own thing. I think there are some, but
Yeah, I think I know one that's based in the Nextdoor Foundation. There's several parents of young children with autism, and there's a parent coordinator named Carla Jackson who is organizing them and having them meet on a regular basis. I know the Autism United of Wisconsin, formerly the Autism Society of Southeastern Wisconsin, has support groups. And I believe there might be some kind of organized through the county. I think what's really important is for parents to feel welcome with the individuals that they're that they're meeting with, that they feel like they can understand each other's experiences. So I think there's a need for more support groups, definitely.
Mhm. You know, as we continue this conversation and we're looking at, some of the challenges individuals with artistic characteristics have, um, I was just wondering, as far as, Dr. Elizabeth, as far as you working in different research, are you doing something else now with research in this area?
I don't know. Yes, I am. I think my video went out. Can you
It
see
did.
my?
Yes, we can hear you. We can hear you.
Okay, you can hear me. Okay. So yes, so one of the things that came out of our book, it has several chapters, and there was a community chapter where a lot of the families that we talked to were really talking about the fact that their kids are getting older. Um, there were families that we talked to who had girls with autism, and a lot of them with boys with autism, young men with autism. And there's this concern about law enforcement, and as their children tried to navigate the community either with them or independently, what's going to happen when they're walking down the street and doing some kind of self-stimming behavior to calm themselves down, and somebody sees it as like they're on drugs or drunk or something, and they get called the police on them, and what happens. And so we ended up getting funded by the Spencer Foundation, the Research Practitioner Partnership Grant Program, to do some research looking at what are Black parents and Black autistic youth and adults experiences in the communities with law enforcement. What do they understand about law enforcement policies and procedures and codes of conduct? And what do they need to know? We also interviewed police officers, and we're still trying to interview more police officers. If that's been really a struggle for us to get police officers to talk to us. For whatever reason, there's some reticence there, but really we don't want to have a one-sided understanding. We want to be able to talk to police officers to understand their perspective. It's not a gotcha. It's like, we have to understand the whole 360-degree perspectives. When they're showing up to a call, what are they concerned about? What are their procedures? What are things that might lead them to do X or Y, right? And through all of that, we've learned a lot, and we're working on developing an educational program that would be used with Black caregivers, their autistic youth and adults, to basically understand themselves, their emotions, their sensory reactions, and how to navigate police in the community. And so we're in the process of finalizing that, and then we're going to be recruiting folks to test it out, to see if it helps, if it works, because the parents that we talked to were saying that we either try to have this conversation, the conversation that you're supposed to have with your kids about police, Black kids about police. We try to have the conversation, or we don't know how to have the conversation, or we have not had the conversation. And we really don't know what we need to be worried about with our children, but we know we're worried and we're concerned. And so we created this program as a way to address that.
I'm just wondering, when you mentioned that, are there any identifiers, like when individuals are like walking down the street and they're by themselves, and like, I know that like people that have different health challenges, they might wear like this wristband to kind of let people know, like maybe if they're allergic to something or whatever. So how can someone identify those individuals and not think that they're just, on, out there or something like that, but they do have a challenge?
First, I would think it would start off with people knowing, researching or doing some things of knowing what autism, uh, what it is. Everybody, I don't know that there's a certain look. There's certain characteristics that people do, but sometimes you find people like my son will mimic to himself and like that at times. But you see people walking up and down the street rapping to lyrics to songs or whatever. So I don't know that that's an identifier. I think the best thing is to put yourself in a situation where you can learn more about it.
One of the things that I've I think I have like the radar for different abilities, but I definitely feel like when it comes to autism, I can spot it even with an adult, or a young child, just because of living the life, and I'm sure other moms and dads can say the same thing. But some of the characteristics would be, like Tara said, maybe singing a song, rapping and not having headphones on or not having earbuds in and just going on with the music. That could be, because I do, I know that my son loves music. He doesn't, always sing different songs. But when he does like a song, like Margarina or whatever that song is, when they're doing this little action, like that movie, what is that movie called? The Transylvania something. That one of the scenes in one of the movies, one of the different, they have two different ones. He'll stand up and he'll start doing he'll do it exactly like they're doing it on the TV. And so they're really, really able to pick up things and hold on to that and remember things, and be able to mimic, a lot of things. But, one of the signs could be, just it's really hard to really explain it, but you just kind of pick it up. But if you see someone out and they might seem like they're talking to themselves, or they're spinning in circles, or they're rocking or walking on their tippy toes, that could be an indicator. And I would say, if someone seems all right, then they're all right. Don't, have to worry about it, because they're out there and maybe their families feel comfortable with them, traveling about. But it's not that hard to identify. Children with autism don't look like autism, and autism doesn't have a look, but the characteristics are there sometimes, and sometimes not. Sometimes you don't know.
Yeah, and I think that's what's so interesting about it being a spectrum, right? And I think, yes, what Tara said about people needing to learn and understand more is really critical, because the more you learn, the more you understand. You can't, like, there isn't a type, like Veronica said, because if you start to say everybody who rocks is autistic, then you start to think that there's only certain signs. And if they don't have that sign, they're not autistic. If they do have that sign, then they are autistic. And that could be not the case. I rock a lot. I have a sister who rocks back and forth when she's sitting and thinking, right? So we have to be really careful about not, essentializing things. Having said that, once you learn and understand more and more and more, you start to be able to notice the constellation of things that might be an indication of autism. And then, but you can see for law enforcement how that could be really problematic, right? And so you were asking about, like, is there like a bracelet and things like that? And, there are these different tools, like lanyards that people wear around their necks, bracelets, on your driver's license, like having some kind of code where, if the law enforcement looks at it, they can say that there's a person with autism in this car. But, somebody might not tolerate having something around their neck or around their wrist, right? So those are the kinds of things that, it's hard, because it might work for one, but it might not work for all.
Joining us today at the table. You all are actually researchers, and you have actually published a book. It's called The Resistance, Persistence, and Resilience of Black Families Raising Children with Autism. And it's really time to go. I hear the music in the background, but I want to thank you all for joining us today and letting the community know that we need to just be a little bit more mindful as far as people that are artistic and how we view them and how they also see us. I think that's what I heard from Veronica as well. So I want to thank you for joining us at the table. And these are actually representatives from the University of Wisconsin-Milwaukee. And they have done and are continuing to do research on artistic. I want to thank you all for joining us at the table today. We look forward to talking with you on other issues. And everybody have a wonderful, wonderful day. Be blessed. Thank you.